Thank you very much, and welcome everybody to this meeting of the work group on Senate Bill 460. I'd like to thank everyone again for their participation and for spending this time with us this morning. At the close of the last work group meeting, there was a discussion, and I apologize, I was traveling and was not able to attend that work group meeting, but I know that during that meeting, towards the end of that meeting, there was a discussion about having the program housed within the Maryland Insurance Administration. And so Senator Augustine and Delegate Collison in particular asked the MIA to take some time offline and to work through a proposal, if you will, about how we could establish a consumer health access program for mental health and addiction care at the MIA, which would serve the goal of acting as a centralized coordination mechanism for both connecting people to care and helping them to access payment that for programs, insurance, et cetera, that will help them to finance that care. And to do it in a way that would take full advantage of all of those resources that already exist, both in through the government and through the private sector, while at the same time being that connective tissue that makes sure that people don't fall through the cracks in moving from one group to another. And so my very capable team at the MIA came together. We spent a lot of time on this, and we have prepared what we believe is a viable program option. We have had the opportunity to run it briefly through Senator Augustine and Delegate Collison, but what we want to do now is preview it for you, what our proposal, based on what we understand the desire of the working group and the General Assembly are. And so what I'm going to do today is, in the interest of time, I'm not going to do introductions. What I'm going to do instead is focus us on just walking through what is at this point more of a concept piece, laying out what this could look like, talking a little bit about, while it wouldn't find its way directly into legislative language, the mechanisms by which we would hope to accomplish these things, bringing together the existing resources at the MIA, other state agencies, but in invigorating a navigator program, creating a peer support counselor certification and education program, and bringing these pieces together. So I'm going to walk through this with the idea of using this time to outline what we envision, and then giving people certainly an opportunity to ask questions today. But the real intent here is to walk through it and then send out this outline for then people to address it and send their comments in as we begin to work toward potential legislation in order to implement this and get those comments. And then at our next meeting, walk through what could be potential legislation. So with that background, I am going to go through the very scary exercise of trying to share my screen and my, oh, but the host has disabled screen sharing, so I can't actually share my screen. So Sue, are you still there?
I'm still here.
Suzanne, so can you enable me to share my screen? Or I can forward the document to you and you can share that document.
Let me try. Okay, try again, please.
There we go.
I did it.
Yeah. All right, so I am screen sharing. Okay, hold on, I don't know why my thing has got really strange what it looks like. Can you see the document?
Yes.
Are you able to see a document on the screen?
Yes.
Yep.
Okay. So my screen looks really weird suddenly because I'm sharing, but that's okay. Just give me one. I can't see anybody's expressions is the problem.
There's a message. Will this document, will you share that document with everyone?
So it tells me I am screen sharing and some of you can see it. Yeah.
Yep, we can see it.
Yes.
Yeah. And what I'm just saying is my screen has collapsed, so I have nothing that I can see other than 4 faces. So not sure why that's happening, but it probably doesn't matter. But what it means is that I can't see your hands. I can't see questions while I'm screen sharing. So, so I think, and I'm very apologetic that I'm taking your time this way, but what I'm going to do is I'm going to actually stop sharing, and I'm going to forward it to you, Sue, and ask you to share it, because I think that way it'll be easier, frankly, for me to be able to have a rational conversation and, you know, catch people's eyes and questions while I'm doing it. So just literally give me 2 seconds here.
No problem.
Okay, I've just emailed it to you.
Commissioner, will we be able to get a copy of it so we can share it among those that are smarter than we are to get a comment?
Yeah, that's the plan, that I wanted to walk through it together and then after this meeting, send it out to give people the opportunity to give more detailed comment. But I just didn't want to send it out in advance, kind of in the abstract. That just didn't seem to be a particularly productive way to go at it. Do you have it, Sue? Okay. So could I ask you to share it on your screen?
Sure. I just sent the Word document through the chat. It looks like you have to make me the host now that I made you the host.
Okay,
So it's not allowing me to share. I'm sorry.
that's okay. I don't know how to do that.
If you click participants,
Okay,
it looks like a little pop-up screen like the chat comes up.
Yep.
You should see yourself as Andrew Tress. And there's if you hover over it, there's 3 buttons.
mhm.
And then you should be able to make me the host.
It doesn't do that. It says Andrew's the host.
Andrew, can you
Want me
try?
to just share my screen?
Please, if you can.
Sure. One second.
I'm sorry, guys. I think that there are 2 people who have their hands raised. Are there folks that had questions?
Yes, we have Laura Mitchell and David Stewart.
Okay, so Laura, do you have a question?
Host disabled participant shares screen sharing. It says I am disabled from sharing it.
Okay. All right.
Let's see.
Just hold with me for literally 1 more minute. If I can't get this to work, I'm just going to share my screen.
I do see Corey listed as a co-host on my list of participants, perhaps.
Yeah. Okay, Corey, do you want to see if you can share the screen then?
Sure. I don't have the document, so you may want to share that with me, but let me just check. If I can-
Give me, I think I have an answer. I think I figured it out. Hold on.
The document is in the
I've
chat.
made you the host now, Susan, and I had to hover over your name. Sorry.
Right.
Thanks, Cor. Okay, excellent. And again, my apologies for my incredibly poor skill sets where stuff is concerned. All right. So what you see in front of you is the draft outline of a program that could be housed at the Maryland Insurance Administration. And what we've done here is just literally outlined, as you would expect ultimately legislation to look like, by hitting, the establishment clause, the purposes clause, et cetera. But within each of those, taking a little bit of time in italics to think about the kind of functions that the program would, how this would be carried out. So the simplest one is the beginning one, which is the existence of the program, and having it as an independent division of the Maryland Insurance Administration. Then the next part, if you just want to go up just a little bit to purposes, what we've tried to do is identify what are the core purposes of the program as it's been envisioned. So, for example, identifying and coordinating consumer access to public and private behavioral health care resources. So that centralized function of taking the time to catalog care and assistance organizations, maintaining updated resource guides, and assisting program participants to access those resources. At a really high level, the idea is this is the connectivity that has been envisioned for this program all along. Then the second purpose would be to assist consumers to access behavioral health care services. So that's been a core component of the desire here, is to make sure that we connect people into care. And so mechanisms for doing that would include having us establish a centralized digital intake, tracking, task management, and reporting systems for people who are seeking assistance from the program. It's really critically important that we have a centralized intake system, not just, as we bring people in, but in order to track their experience and the timeliness of responses, so that this would serve as a central vehicle where navigators, state actors would be entering information in, so that we could have really true case management functions and be able to look at things like timeframes, and reasons for denials, or, issues in getting a bed, et cetera. So the idea would be that we would create this centralized system where we could really journey with someone from the time they first come into our system all the way through their experience. We also would be looking to identify and access and leverage behavioral health provider appointment systems that are established outside of the program. So, for example, the Maryland Department of Health is in the process of implementing, I believe it was House Bill 10 something that passed in 2020, where they were directed to create what is essentially a listing of available mental health providers. And they are in the process of doing that and have begun to roll some of that out. So we don't need to recreate that, but we do need to tie into it, and we need to leverage it. In fact, the MIA, we're going to have a conversation with the gentleman at MDH who is overseeing that project, to see exactly where it stands and sort of what their time frame is for their waves, or the completion of it. So those are the two mechanisms that we would begin to utilize to help assist customers to access those services, at least from an electronic standpoint. We would also see, but there's more to come on that. That's not all there is. We'd also look at assisting consumers to obtain payment for behavioral health care services from commercial and government health plans and public or private financial assistance programs for which they qualify. I think one of the things we learned from New York is that in addition to helping people connect to health insurance or other means of payment, it's also very important to understand and help people to understand where they can get assistance from other organizations that can help pay for the parts of care that might not be covered. So I think that's an important resource as well. So in looking at this, in how this would play out, what we would expect to actually be doing is helping consumers to enroll in health plans and assistance programs for which they qualify. That would include directing them to the Maryland Health Benefit Exchange for insurance coverage and Medicaid enrollment. It might direct them to navigators, for example, to look at private assistance programs. We would certainly develop a navigator system that would be the spokes, if you will, and direct consumers to navigators to interface with providers and health plans in which they are enrolled to confirm and coordinate coverage. In the event of coverage denials, we would be referring consumers to HEAU, the Appeals and Grievance using unit of the MIA. So using existing resources and programs to pursue their contractual and administrative remedies for coverage denials. Some of those units, particularly HEAU, would very likely need to have additional resources and expert assistance with the more complicated behavioral health care cases. But that's the sort of thing we would envision that the program would be able to contract with those experts, as, for example, the New York program does, to help HEAU where it's necessary for them to assist consumers with their contract and administrative appeals. And then in the event that administrative actions are not successful and the consumer is still left with the denial, we would recommend that, as New York does, that consumers are referred to legal resources that currently exist to pursue judicial remedies for coverage denials. The other, moving back to, again, the purposes for which we exist, which this program exists, would be to provide a toll-free telephone hotline to respond to requests for assistance by consumers and providers who are acting on behalf of consumers and individuals within the state's behavioral health crisis response system. So very much language that was from Senate Bill 460. And our goal would be to step back and think about how can we leverage existing hotline operations, so call center operations such as a 211 or an MHBE, to be able to perform this initial intake and triage emergencies so that there's always somebody available 24/7 to take those calls. I think anyone who's ever tried to go through the practical reality of implementing a brand new call center function understands, how, and you only get one chance to do this right, because if you launch it and you fail, it becomes very difficult to get people to track it again. So what we would want to do is look very carefully at successful call centers and then be able to create this as a program within that existing call center. And MHBE may be the best place to do that. But the 211 operations and the 988 operations are there as well. Again, these are not the things that are set in stone, but it gives you the flavor of what we think, how of living out the purpose and the different the goals of the program. The next point is to provide a website through which consumers and providers, et cetera, can access information about behavioral healthcare services and getting plan coverages. the purpose of that, we would want to establish for the program a standalone website and also an app. So it's branded as the program, and then it within state agencies and other external resources could link to that centralized website. And the purpose of that would be, first of all, to provide a bunch of educational information and links for people that that are looking for that information. But also it's another way to access service. So to be able to, in addition to calling the hotline, if someone for whatever reason wants to go online and request assistance, we would make that available online. It's important that we think about multilingual access and that it's smartphone friendly. And then that would be directed right into the intake system for a rapid referral to a navigator. So if someone were to go online and say, I'm really struggling with this, I need help, they would put that in. That would then immediately, that would generate a request that a navigator in that area contact them to help get them connected. The other purpose of the program would be to contract with qualified entities to act as behavioral health care navigators in each of the connector entity regions. So much as SB 460 envisioned, there would be a navigator entity within each of those regions that would have specified responsibilities that would include following up and maintaining contact with consumers, assisting the consumers to find qualified behavioral health providers, directing them to MHBE and the connector to obtain coverage if they don't have coverage and they're looking for coverage and they qualified for coverage, or for Medicaid, having the navigators track and report information regarding the consumer's experience in securing care and coverage, supervising what I'll talk about in a minute, certified peer support counselors. And then when you come to the point where there is an actual denial, so if they've been unable to assist the consumer in having their health plan give them coverage, and they have a denial, whether it's from a government plan or from an insurance company, to refer them to HEAU and MIA to do the jobs that these agencies normally do in trying to move through the administrative process. And continuing, as navigators and as peer support counselors, there's never intended in this outline for there to be just a handoff. Okay, go talk to MIA now. It's always intended that the relationship be with the program's oversight and the ability of we'll talk a little bit about the structure when we get there, but with the program's oversight and ability to laser in and help in any given case. The concept is that once people enter this program, they will form a relationship with the navigators. They will hopefully be assigned a certified peer support counselor. So someone is really walking with them through their entire process, even though in a given moment, a particular matter may be handled by a different state agency. So even though they would be working with HEAU in the development of their internal appeal, they would still be coordinating and getting information, and it would be the navigators and the peer support counselors who would also be involved with them in that process. The next purpose that's listed is that in conjunction with one or more educations of higher learning in the state, to develop a cost-free certification program to train and certify peer support counselors to assist consumers seeking behavioral health services and health plan coverage for those services, and assign both compensated, I apologize for the typo, and volunteer certified peer support counselors to the behavioral health care navigators. So this would operate somewhat like what Colorado is doing, which is to actually take people who have lived experience and enable them to be certified, to be able to work with within the program. The benefit of doing it this way is that they would fold into the program. They would work under the supervision of the navigators, that they would have specific responsibilities They would be under contract with those navigators. So issues of privacy, confidentiality, it would be addressed and maintained through those contractual relationships and those volunteer contracts. And then the other services are to carry out a public relations and advertising campaign to promote the program. And then importantly, to collect and analyze data. And this gives an example. This is not necessarily an exhaustive list, but the kind of data that we would be looking and that we would be relying on this on the platform and the tracking information would be to look for what are the gaps in behavioral health care resources, the gaps in coverage, the bases, collecting the bases of coverage denials, not just with private insurance, but in other payment plans as well, to look at what are the results of contractual and administrative appeals, what are the results of judicial actions, to track and report on mental health parity issues and violations, on network provider adequacy issues and violations, and I think also importantly, provider directory issues and violations. The goal would be to share that data and analysis with state agencies, but also to submit an annual detailed report to the Maryland General Assembly on the program, including in a sort of, and obviously a de-identified and aggregated form, the program data, and to make recommendations to approve access to affordable compensated behavioral health care. So in order to execute on those duties, what we have talked about is having that the commissioner would appoint an executive director in consultation with the coordinating agencies, so MHBE, Maryland Department of Health, HEAU, and the executive director would report to the commissioner. That is the structure of state government and a division within the MIA, independent or not. However, the goal would be to have the executive director be as independent as possible. So they would actually have a term and they could only be removed during that term for cause. So it wouldn't be, they would not serve at the pleasure of the commissioner. They would not be, they could not be terminated because the commissioner doesn't like, the direction they're taking or what they're doing. The goal, the job of the executive director would be to obviously direct, administer, and manage the program. They would employ and retain their own independent staff to perform services that are unique to the operation of the program. And they could retain independent contractors, attorneys, consultants, and other professionals that they believe to be necessary to carry out the unique operation of the program. And unique in their means, as opposed to the kind of general state government employment related services like, HR or, processing, PIA requests. So the administration, the insurance administration, would provide the executive director with sort of what I'm calling operational support services. So HR, the routine IT, like a laptop, office space, simple equipment, basic transportation services. And we could enter into a memorandum of understanding with federal, state, and local government as necessary to facilitate, any of the things that the program is doing. So from a functional standpoint, it would be housed within the MIA, but it would have a great deal of independence, including an independent sub-budget. Moving to funding, again, we would, as the Senate Bill 460 did, create a fund. The purpose of the fund would obviously be to support the program. The administration, would be typical within the MIA, that if you have a division, our fiscal unit technically manages that fund strictly from the sense of the interactions with, with literally sending checks out, processing expenses, et cetera. But the fund itself would, and it would be a sub-budget, and the control over that, subject to, all of the rules that govern any use of state monies, would be at the discretion of the executive director. We would envision that there would be a contribution to the fund from the administration from its own budget. We can talk about that in terms of a percentage, but, we believe that some of the work that would be done by the program would overlap with work that the administration might already be doing. So it would seem appropriate that the MIAs, as an independent agency, that its budget could support some of the work of the program. And then any funds that are designated by the state, and then, the typical summary of, where funds could come from, investments, et cetera. The fund would only be used for the operation of the program. Two important parts of this program, if we think about, again, the idea of spoke entities, the behavioral health navigators would be a very important part of this program. And so much as MHBE is set up this way, we borrowed from the MHBE enabling legislation and thinking about sort of the component parts and how they would fit together. And I think we will want to utilize the concept of navigators. So identifying and appointing navigators, laying out what their specific functions would be, their qualifications, their selection criteria. There's a lot of information from Senate Bill 460 that we haven't loaded into this yet, but that lay out what the necessary sort of qualifications in terms of diversity and in reflecting, the population, and then talking about their duties, their compensation, which would be contractual, and the basis upon which you might have to at some point have to terminate a relationship with a navigator. And we would look to be doing something very similar with peer support counselors, so that we're able to draw upon people who have lived experience and who are interested and want very much to assist others and walk with them through this process. But we also want to make sure that they have very specific roles, that they have training, and that we can enforce, if you will, the privacy considerations by having them have actually a formal role within these programs. And then the advisory council is something that would be very important to maintain. The council should, as Senate Bill 460 did, and as the, again, drawing on MHBE, reflect the gender, racial, ethnic, and geographic diversity of the state, have a cross-section of stakeholders. They would be appointed by the board for a term of no more than 3 years in a manner that provides continuity and rotation. This is consistent with how MHBE's advisory council operates. We would look at 15 members. This is similar to, but not exactly the same as the council as it is in Senate Bill 460. All of the state agencies are exactly as they are articulated in Senate Bill 460. But we have, rather than having, you must have one person here, you must have one person there, that the executive director would designate 9 of the members that would have these to make sure that each of these characteristics were covered. And then the council would meet quarterly and perform these functions, looking at the administration and operation of the program, recommending improvements to the program, reviewing the data to be included in the annual report, and making the recommendations that would find their way into the annual report, and then advising the executive director on any policy issue as to which the executive director is seeking advice. And then from an annual reporting concept, the idea would that the executive director would provide a report to the General Assembly by December 31st each year. That's an arbitrary date. It could be December 1st. But what it would include would be a summary and accounting of the program activities, an evaluation of the performance of the program, a fiscal accounting, and then in a de-identified or aggregated method, just depending on what was appropriate given the subject matter, it would talk about, the number of consumers seeking services, the number of successful referrals, the number of folks seeking assistance that had health plan coverage issues, the basis of those issues, the denials, what happened after that, what happened with contract administrative appeals, what happened with any judicial actions, looking at mental health parity issues and violations that were identified, network adequacy violations, provider directory issues, and importantly, identifying gaps in treatment availability, beds, providers, et cetera, and then making recommendations to the legislature about how to improve this entire, improve the program and also improve our delivery of mental health and compensated mental health. So that is a wordy, and I thank you for hanging with me, summary of what our team has put together as a starting point for discussion. I'm going to ask you to drop your screen, if you would, Suzanne, and we can certainly have discussion. What I would do is invite perhaps Senator Augustine and Delegate Cullison to share anything they would like to share about the outline, since they have had an opportunity to review it, but let them perhaps kick off our discussions.
Commissioner Borrena, I'll say thank you. We've talked about having this effort. You all put a lot of work into it, and I really do appreciate it. I do put it to the work group to hear from other stakeholders, their thoughts, and but I really do appreciate the hard work that's been put into this. Thank you so very much.
Thank you.
And I would add my thanks as well. I mean, I think this is an extremely comprehensive outline. And when I look at and consider what we've talked about in the last 5 meetings around the intent and purpose of the CHAP program, I think you have clearly defined in this template exactly what the program will do. I mean, certainly there are details about operational stuff, but in terms of the services it will provide, the things that are needed to be able to set it up, is all in this outline. I know the senator has asked us a couple of times to look at the bill 460 and identify all of the different functions and goals, and I think that's what you've done and pulled it into this document. And then you all have heard me say this before, we are taking advantage of what we have in place already with the program set up this way. So there's actually overlap. So we actually, I'm not looking to save money on this, because although, I want to be fiscally responsible, but we're already spending money on some of these activities, but they're not coordinated among the agencies. What this program will do is coordinate those activities. So I'm very excited about the proposal. I mean, I actually only have one question, which is extremely rare, but I'm look forward to hearing the comments from the work group. Thank you and your team for this work. It's terrific.
Well, thank you. And I guess what we'll do is we'll just ask people to raise their hands. I know that I'm throwing this at you, right? So the expectation wasn't that this is going to be our only discussion. The expectation was to sort of walk you through it. And the italicized information is really how we might be able to operationalize these purposes, just to begin to get a flavor for that. So if people don't have a lot of questions or comments, that's okay, because we will have a more rigorous discussion after people have had an opportunity to provide their written comments. But I'm happy to hear what people have to say kind of off the top of their head. So Ms. Seacott?
Hi, Commissioner. Hi, everybody. Thanks for this. I guess I just want to piggybacking on what you were just saying. I think we need a little time. I don't want to speak for anybody else here. I certainly need time to kind of do a side by side with this and try to figure out, kind of what the questions are. It still is to me just I guess an overall question about MIA, this sitting within the MIA, but clearly we're talking about this entity being able to do things that the MIA currently can't do, and sort of, I'm assuming then that's the vision for the legislation to enable all of this within the MIA. And I think we just I want to spend some time looking at the bill as it passed the Senate and this proposal, and try to identify kind of where the differences are and be able to ask questions about the thinking behind some of that. I do appreciate that, it seems to still be somewhat of a hub and spoke model, with the MIA being the hub, or this entity within the MIA being the hub and being able to contract with other entities. Off the top of my head, I can see one of the things that is different than the legislation is that this program would not provide any of the legal assistance that people need, but instead refer people to legal assistance. And that may be something that we can talk further about, related to how it was envisioned. And I think it's a legitimate issue that you raised as well, that the HAU will need more resources. We know that a tiny fraction of what they currently do with the cases they look at have to do with behavioral health. And so we want to make sure that, we under an assumption that there will be a significant increase in that they would need resources as well. So I think I will need a little time with my clients to look at this just a little more in detail.
Great, thank you. Yeah, and I mean, you're correct. I mean, the concept here is that when you get to the point where you are in an adversarial circumstance, that you would pursue those contract remedies or administrative remedies through the government agencies that already exist. Those government agencies, as I think you said, would at least HEAU and as HEAU has said, are going to want and need additional resources, including the ability to contract out, much as the New York program does. And with regard to the judicial piece of it, it would again be a referral program, much as New York's program is, as we heard from their executive director, that they do not actually pay lawyers to file lawsuits in the courts. And that's frankly what's on their website, and that's what their executive director told us. So we kind of went with that model, particularly, at this initial stage of the legislation. But happy to hear your questions, when we get to the next phase. I think the next person that has their hand up is Ellen Weber.
Thanks, Commissioner Borrain. I had a number of questions, and so I'll ask a few, and then if others don't ask them, we can come back to them. I think the initial question that I had was primarily around something you just touched on. First, the referral to legal resources. So I want to ask you a little bit about who you actually envision are the legal resources that you're going to refer individuals to in the community. So that's one question. The other question, though, that I had is, and quite frankly, how those resources, how a client is expected to afford those legal resources, right? Because I do differ a little. Oh, can I just finish? I do.
Well, yeah, because I just want to make sure you pause at the end of your first question so that I keep it in my head so I can respond to it.
Sure. I do differ a little bit in terms of your, the characterization about sort of legal representation. And I mean, it may be a little bit more semantics, but the organizations that do get that are specialty organizations with CHAP, they are paid to provide legal representation to clients, and they do represent those clients in administrative matters. I think, as we've all talked about up to this point, they haven't been filing cases in court, but nonetheless, those are resources that the client does not have to pay for. And so that's a really critical point, to expect an individual who has limited resources to then have to pay an attorney when they have to pursue some other kind of legal remedy is a huge question. So that's that is that first question.
So
This-
what I don't, so two things here. First of all, this cannot be just my vision or the MIA's vision. It will be and should be the vision of not just the General Assembly, but the executive director when they are hired. Because this isn't going to be a program where every element of the program is laid out in statutory law. The statutory law will lay out the purposes of the program and enable the development of the execution and operation. So I think the thing that's most important is that our team thought through how this program could be could operate from a practical standpoint, but every nuanced detail of what that means has to be the work of the executive director and the program itself as it comes into being. So that's the first point. The second point is that when we talk about legal representation, the way I think of it, and you know what, we're just going to have to agree to disagree with what we think CHAMP is doing, because I know that you have what you've said, but when we talk to the executive director and we talk to the program, what we hear is something different. So in any event, what we want to do is focus on this program, right? And how it will work in Maryland. And we can be informed by any number of states and how they do things, but we can do things our way here. And I think with regard to legal representation, there is a difference between entering into a formal attorney-client relationship with an individual in where you would separately represent them under the rules of professional responsibility and manage their case as their individual lawyer, which is one way of talking about legal representation, versus the ability of organizations, individual lawyers or advocacy groups being contracted to a program or to an HEAU to help them carry out their legislative function in providing support services as they do today to Maryland consumers. So for example, it may very well be that an organization like the Legal Advocacy Center is contracted with HEAU to work alongside HEAU attorneys in helping those attorneys to address mental health issues, because in those complex cases, as Ms. Camerata indicated, it would be helpful to them to have those additional resources, et cetera. But that's not the same thing as saying we're going to hire Joe Smith as a lawyer to represent Mrs. Jones with respect to her case. So I think that those are two different things. And at least at this phase, the idea is that lawyers as lawyers and legal advocacy groups would play that advisory vendor contract role to agencies or organizations like HEAU. That's where the funding would go, and also be a resource at the navigator level, where people are looking for help in that first phase of discussion with their health plan before there is actually a dispute, before you know that there's a denial, before you know there's a basis for an appeal or a grievance. So hopefully within the context of, we're not planning this program today because that's the job of the program when it comes into being. I think that's the best way I can answer your question. I also think that by the time you talk about getting into filing a lawsuit in court to pursue judicial remedies, you are correct. We don't envision that being something that this program is going to do beyond the referral to existing resources where there are sliding scales and there can be free legal representation based on the organization. One thing that you may think about and that we as a state may think about is the role that legal aid can and should play in bringing in people who do have expertise in filing lawsuits and making them available to represent individuals who qualify for free legal assistance through an organization like legal aid. which could create, just as they have created a long-term care unit, could create a behavioral health unit.
Thank you for that. I had one, one other at least two other questions. One is a question about how do you envision the HEAU handling the sort of initial denials that they currently don't handle? So Medicare denials, Medicaid denials. I know they do handle ERISA matters, but then there are other types of insurance. If there's veterans insurance, if there are federal employee benefit programs, those are all items. Again, I know we're using CHAP in a variety of ways, but again, that was what that was the vision for CHAP, that there would be no wrong door, that this entity would handle all of those various kinds of insurance. So for the for the kinds of insurance programs that HEAU currently doesn't provide assistance in, how would you do that?
Well, again, I'm going to say that I don't have a specific vision, that I think the language is broad enough to say we're going to use existing resources to the extent that we can. And part of the goal of, once you set up a program like this is to walk through the specifics as the executive director implements the program. But, I would say that what we would expect to do is come alongside HEAU, understand what it understands its abilities are, where it can reasonably expand, and then to the extent that it's necessary for the program to be able to have those resources, where's the best place to house those resources? Maybe they're in the program. Maybe it's the MIA's consumer advocacy group, which has has a broader ability. So I'm not trying to nail down in this document every single operational detail. What I am trying to do is lay out the purpose of the program, recognizing that the exact methodology by which each particular need is going to be met is necessarily going to be part of the actual development of the program once it comes into being. I don't think there's an idea that it must be HEAU. I think that's a conversation with HEAU and what resources exist. The goal is to make sure we leverage what's there, but not to say if it's not there, it doesn't exist.
Thank you for that. Do you have two other questions? You raised a lot of issues around a group of peers who would assist, and again, I couldn't get quite a clear idea about this, but you made some mention of a certification program. There is an existing peer certification program in the state. So how would this differ from that? So that's one question.
I'm not sure that it would, Ellen. I think it doesn't necessarily have to differ than that. It may just be a conversation and being clear that that's what this is. What I've tried to do is create a placeholder, but if that's something that you feel is already completely addressed and doesn't need to be customized in any way, then please share that with us in your comments.
Thank you. And then the last question is, what are you envisioning the cost of your model to be?
I have absolutely no idea. So I don't know what the fiscal note was on the last one, and I think we would have to work with the General Assembly. What we were asked to do is lay out a proposal for how this could operate. And I think we would need to hear from the experts, within about what the fiscal note would look like on this. I do know that that we can support the program within the MIA for what are these operational, like general operational, like giving office space, the sorts of, so they don't have to, the program doesn't have to absorb any of those pure administrative, pure practical costs. So, that comes out of the equation. And I think that there is likely to be some overlap in what the MIA would, and particularly our consumer education and advocacy unit would be doing. so that it would be appropriate to use a portion of the MIA's budget to support the activities of the program. So I think that takes some pressure off. But beyond that, I think that we will need the fiscal experts to be able to put a price tag on the program.
Thanks very much.
Let's see, Ms. Rivkin?
Thank you. Hi, everybody. So I want to start off by saying at first blush, this is wonderful. I think you've really hit the goals of ensuring that citizens in the state of Maryland can get the care they need and get access, and hopefully reduce a lot of the frustrations. And this seems to me to be in a very collaborative approach, as opposed to like a regressive top-down type of approach. So thank you. I mean, obviously we're going to have to, as Ann and Ellen said, review it a little bit more, but overall, I think this looks excellent. There are a couple things I just wanted to mention, and I take to heart the fact that you said you didn't want to be prescriptive in this, and so it's going to be the executive director's responsibility, but just things I wanted to highlight that I don't know if they can be added in here or later I can continue to raise them. But part of this is, a lot of this is what's happening when a member is frustrated because they can't get care, finding an appointment with their carrier, be that Medicaid, be that a commercial carrier, be that Medicare. And I would love to see if there's some way to put in this approach that it's really important for whoever's doing this type of assisting of consumers should become very, should be educated on each carrier's programs, because it'll be so much easier if somebody called and said, for Care First, for example, and said, I'm having the most difficult time getting an appointment with a Care First member. And the navigator or whatever we call this individual would say, let me tell you about the different programs. I know exactly where to go to a link. I can find how they have developed, because we have a number of different programs. And I think it will alleviate a lot of the hurdles that could happen. So I would love somewhere in this in here that it would say that they become well-versed, so they spend time with each carrier and get to know the programs, and that might be through Medicaid as well. That's
So
my first
just
point.
to quickly respond to that one, what I would say is, and this is probably not as fleshed out as well as it could be, but what we've talked about a little bit is utilizing the rapid response program as a model for the navigators. And, so for example, and this is primarily with property and casualty, but our consumer education and advocacy unit has a program that's called Rapid Response. And what it does is it's a way for a consumer to be able to reach out to the MIA and, without going through a formal complaint process, identify an issue that they have. And we have a direct line right into each carrier. So each carrier identifies their troubleshooter, and maybe more than one. And we're usually able to get that company on the line in the same day and address the issues really quickly and cut through all the red tape and get the issue resolved without having to go through a formalized process. So that is something that we've been experimenting with from a healthcare perspective. But I think we would look at doing something very similar to that at the navigator level, where you know who to go to within an organization, whether it's a company or a government program, to try to cut through the red tape and get relatively quick coverage information and work with somebody. So that would certainly be a goal of the program. One of the benefits of the program would be government talking to government about how we're going to take care of our consumer.
That's fine. I mean, we can, I think I'm saying something a little bit slightly different, but I think that's something that can be ironed out. My point was really, if someone called me and I'm the navigator and I say, oh my gosh, let's go together, let's get on Headway. For example, I've talked to you about Headway,
Mhm.
and let's see if we can get you an appointment right away. So hopefully in 15 minutes, an appointment can be
Yeah, we were actually saying
achieved
the
because
same
they know
thing.
the programs. So perfect. So it's not necessarily calling somebody that may, I still think you're right, that there needs to be a person in each company. That's wonderful. So that's just an editorial about how I would hope that some of this would work. The other thing is when I look at the data collection, food for thought is I think all the elements, and I can't even find it right now, the data collection was fine. However, I'd love if we could also look at some of the highlights, like some of the positive things that have come out of here. Like go back to the carriers again. Let's just say 90% of all calls were able to be achieved with an easy access through calling the back of a card or going to their website, as opposed to having to just focus on how many appeals had to be done, what were the denials. And so we might be able to get really nice lessons learned, what worked and what didn't work, and where were the positives. And wouldn't it be a fantastic thing if everybody learns about the different programs that are available, and then we could say most of these, or 5% of these, were achieved with just calling or finding, access in a quick way, as opposed to having to go through a formal appeal. And so if we can just, as you're identifying the different data elements, would be wonderful if we can figure out a way to add some of those as well that they collect, because I think we'll get some lessons learned from that as well.
I think that's interesting. And whatever group comes together ultimately to build the tracking system. I mean, what we talked about was the idea that, each step of the journey, there is data that is put in, and some of it is drop screen type stuff, so you can track it very easily for statistical purposes. Other is including more detailed information, but the most important part of that is having a tickler, right? So if a person is referred to a navigator, they must respond within X amount of time, and if they don't respond and check off that they've responded within this system, a case/task management system, that goes to the program. So the program can intervene, and the program has the staffing that's available to make sure those phone calls happen. So, if we can work through that type of a program, there are many, 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 many data points that can be captured pretty easily, along the way of what happened with respect to that particular individual and where they ran into problems and how those problems were resolved, and most importantly, the time frame in which they were resolved. So that tracking thing becomes, we think, a really important backbone, and it would make sense to include in that story, where they're able to resolve something by accessing a website and making an appointment versus where they have to actually make a phone call.
Exactly. That's my point. And could it have been done in 15 minutes versus through the whole process? So it would be nice to be able to see, and we may end up learning a lot from that the majority are resolved quickly, or the majority are resolved because they have to be appealed. And I don't know the answer, that they need, additional help. But that I think will help us understand and do a better job for all of us to make sure that people are getting the care that they need in a timely fashion. So thanks.
So I don't see anybody who's on the panel. Miss Kim?
That's because I was literally putting my hand up right when you were starting to look. I have a few thoughts because I had the same question as Ellen about sort of the Medicaid and Medicare, which, as you all know, our office does not handle. And when I'm thinking about, best practices, I think it makes sense for HEAU perhaps to pick up the Medicaid appeals because it's a state, it's a state-based program. Having said that, I would have to truly get an idea of what the data is on Medicaid denials in the behavioral health space. And when I say pick up those appeals, I don't necessarily mean, I've long thought HEAU should be assisting Medicaid consumers with all of their denials, but we absolutely don't have the capacity to do that. And it is a unique area of law, right? I mean, the Medicaid coverage program is very different than any other program, right? So it would require, you know, expertise and AAG or AAG's expertise, depending on sort of the volume of cases there. So having said that, we have an intake program. We have, you know, a computer program where we put in appeal deadlines. And I mean, like sort of, again, taking a program that already exists and using the resources we already have and buttressing those resources to sort of take that on. With regard to Medicare, although I doubt, you know, I mean, I don't know what the numbers are there. That too has, you know, the Medicare coverage rules are very, very different. We handle Advantage plans, the private side. We handle coordination of benefits, as you know. But like New York works with the Medicare Rights Center, right? They contract with the Medicare Rights Center because, again, that's very complicated Medicare rules. And so our CHAP programs help consumers with Medicare appeals. And so I know from conversations with consumers that some are better than others, but because they already have sort of that expertise, we may want to think about including CHAP as a partner on the Medicare appeals. I mean, leveraging the skill set that they have there. You know, Deb, I hear you, and also Commissioner sort of on the rapid response idea, and Deb saying get to know some of what the carriers are doing. I mean, that works for our state regulated carriers. And we're usually able to do well by consumers with our state regulated carriers. But the majority of cases that we help consumers with are ERISA plans, federal employee health benefit plans. And frankly, those plans are much less responsive than our state regulated carriers. And so, I mean, we may well reach out to Anthem, for example, and we don't get responses. So sort of that sort of idea sounds good, but when we're dealing with these non-regulated plans, we run into roadblocks that we don't have with our state regulated carriers. So that's just sort of food for thought there. Those were my initial instincts when sort of hearing.
Sure. No, I appreciate that, and I'm sure that you will have more. And I mean, you're exactly right, Kim. I mean, part of what if this program comes into being, what needs to happen is, you know, a sit down with the executive director and the stakeholders and the advisory council to stand this up. And you know, you've identified lots of areas where there's going to have to be conversation around who do we connect with and who are the additional, you know, vendor resources that are going to have to be brought into play in order to assist in all of these diverse areas. So, yeah. Delegate Collison, unless you had something else, Kim?
I did. I thought of my last thought,
Yeah.
And that was sort of thinking out loud here. I mean, I can say we are definitely starting. And we're pleased to say we are getting more consumers reaching out to us that are having issues with behavioral health care providers. And when I say pleased, it means more people are accessing care. We're seeing a lot of these national online platforms for folks able to access care. So we're of course getting more complaints, more access to care, more denials of care. And so sort of dealing with these national platforms has its own unique challenges that we're just starting to see. And then we're also, as we're seeing more consumers reaching out and would love to sort of, again, see this considered in sort of this conceptually, is I know New York has a social worker on staff to answer, to help answer their hotline because we, and I suspect, Commissioner, your team has seen this too. We've seen an increase in consumers contacting our hotline with significant behavioral health needs. And, you know, we're not as equipped as we would like to be in dealing with some of the consumers that are reaching us when they're in sort of a mental health crisis, right? We know how to help on paper, but having sort of that sort of social worker crisis intervention person that could sort of perhaps be across all the lines, I think would be, you know, an important component of this and And that may have been in the outline, Commissioner. It was,
And it was, and, I think we've had a lot of things that are operational possibilities because ultimately the legislation is unlikely to be that detailed, that's what you would see in regulation or you would see, as the operation unfolds. But, part of what is intended is that the program has the ability to engage in all levels of what they need in order to make it happen. And, we don't have to create something completely anew, right? Like we don't have to set up the infrastructure of a brand new call center. We can take the infrastructure that exists in like an MHBE, but expand that and have specially trained people to answer those particular calls, right? But if we're really looking for something that's available 24/7 and that's going to help people in crisis, somebody's got to answer that phone every time, right? And, that's not a social worker. That's a team of people who've been trained to do that level of intake, right? So I think that our objective would be to hire an extremely experienced and competent executive director who works with the council to take exactly those kind of comments, Kim, and see how do you drive them through the program in a practical way while having made sure that the program has the resources that it needs to be able to operate in that way. I'm going to go to Delegate Cullison, and then what I'd like to do is Mr. Stewart and Ms. Bergen have had their hands up for a while. And so Deb, before I come back to you, I'd like to give them, oh, you put your hand down. Okay. I want to give them the opportunity to speak. So Delegate Cullison.
First, thank you, Commissioner. I think that some of the questions that Kim was raising will be addressed in the coordination that already exists of programs that already exist, and that having the hub in MIA, that social worker team of social workers is going to be there to direct people to the right place. So I think, operationally, at least as I interpret the information, I think that'll work out. But I do have two questions that go beyond the executive director's purview, I think. One is the term of the executive director. In the outline, you say 2 years. My question is it renewable? And if it's renewable, is it renewable for how many times?
Oh, I don't think we even thought that far.
Okay,
Yeah, I mean, I would think it would always be renewable.
yeah. I mean, if that's common practice, then that's fine. I just thought if it's not, and 2 years, I mean, my experience in life is 2 years is not long enough to really dig deeply into something. And so, but if you do a good job for 2 years, you can do it again for 2 more years.
Well,
So
2 years is just literally just a placeholder. I think it may be because, and I could be wrong about this, that the New York executive director has a contract. That's another methodology of doing it, is to have them be an independent contractor. The methodology that we had was them being a state employee and have all the benefits of that. But you could choose to do, because ultimately this is this isn't our legislation, right? This is the legislation, Senator Augustine and you, and we're happy to draft however you want, is that we would, you could put in that they are an independent contractor. And that also, may provide more flexibility in terms of their salary. So there are other ways to address the executive director. I went the route of just MHBE because I was looking at that, but made some tweaks to, make them independent and not serve at the pleasure of.
Okay. And then the other thing, just in the definition of the council, I didn't see any representative of the pairs. So I was wondering what the rationale was to not have them represented on the council.
I honestly took Senate Bill 460 and made some edits to that to not be quite as prescriptive about, the last 10 people or 9 or 10 people. So I don't really have a reason other than that.
Okay.
That
that's
doesn't mean
fine.
that that
Yeah,
couldn't be added.
okay. Thank you very much, Commissioner. I appreciate that.
So what I'm gonna do is I'm gonna invite, Mr. Stewart has probably had his hand up the longest amount of time. So I think we can, yep, we've invited him over, and then Ms. Bergen. So perhaps we can hear from Mr. Stewart first and then hear from Mr. Bergen. We have 12 minutes left.
Can you hear me?
We can.
Great. I'll be short. Just in general, I find this very disappointing. And it seems to ignore the actual on the ground expertise of those of us who contributed to the design of the original program. It feels very much like it's making way more bureaucracy. And it seems to be doubling down on things that we already know don't work. And I feel like new is more than justified. And I also, I don't understand why the program as designed by people who have real experience doing this for years and years seems to be ignored. And why is it that we're competition as opposed to an ally? I work with MIA, HEAU, part of the MHBE world. I get all the need for cooperation, but I really don't understand why it seems to me like this whole meeting was designed to just kill the CHAP program and create something that just doubles down on what we already know will not work. And with that, I'll shut up.
Well, you don't have to shut up. I mean, your perspective, of course, is always appreciated. That really wasn't what was in anybody's heart or anybody's intent. Perhaps what you can do is identify, specific things that you think aren't being carried out here.
Well, I can certainly do that, but the whole thing was designed by people who, I've been doing this for 13 years, and I feel like I have a decent understanding of the obstacles and hurdles that people face. I have a lot of experience funneling people to HEAU and MIA, and certainly through MHBE. But I just don't get the opposition to the program as designed. And it's the one thing that's never been clearly articulated in any of these meetings is what is this strong opposition? And I just feel like somebody should name that, because my understanding of these original calls was that we were going to address the concerns with the existing bill. And so far, nobody's been willing to put themselves out there and say what's wrong with it, to name what is wrong with the bill as proposed and actually as passed by the Senate. Nobody's done that.
Well, I think we made an attempt to lay out at the very beginning what we understood the criticisms were, at least as they were articulated in the House. And that was a document that we sent out on the very first day. But I don't disagree with you that there hasn't been a lot of articulation in these meetings that really go beyond what was some of the discussion that was had in the House when the bill got to the House. Although there have been, I think, discussions around, coordination and expense. So I do respect and appreciate your point of view. I want to make sure that we give Ms. Bergen the opportunity to speak as well. Did we bring her over, please? Ms. Bergen, are you there?
Yes, I'm here. Can you hear me?
We can.
Okay. So I agree with a lot of David's criticisms, so I won't restate them. But I think one of the concerns that I have is that a lot of the resources as they exist in Maryland are really siloed. And as a consumer who has had, private insurance and Medicaid or private insurance and Medicare and Medicaid, it's really difficult to navigate. And I guess the way this has been designed, it doesn't seem like it's really adding the resources necessary to address what we don't have and like where those silos aren't working. It almost seems like it's just, you know, adding something in name only, but not really fixing the underlying problems. So that's one really big concern I have. And I just also have concerns about when consumers call, who's like, are their stated interests being represented? And then the final thing is I am struggling with the idea of how peers were discussed and how peers were designated as working under navigators. I feel like having people with lived experience and including them as peers and not as equals, I guess, is really problematic to the program structure. I think we need to not assume that people with lived experience are kind of less than or could only participate in a volunteer capacity or need a separate certification in order to maintain confidentiality. To me, that implies that there's some sort of implicit bias in kind of the concept of this program. And I think that really needs to be evaluated. I'm a third-year law student. I also have a mental illness. That doesn't mean I'm incapable of, working in a program like this or helping people in other ways. But I think we need to look at that on a systemic level and really kind of think of how are we conceptualizing people with lived experience. They might be in a tough place when they're calling, but that doesn't mean that at other times of their life, they're not really valuable members of our society. I mean, and they are when they're calling too, but we all struggle. These are human problems. They're not like separate people with mental illness problems or people with substance use problems.
No, I thank you for those comments. And just very briefly, I think if we didn't think they were valuable, they wouldn't be reflected in the program anywhere. I do think that they're valuable. And the goal of having them connected in a particular way is not to make them subordinate to. The navigator is an entity, but not to make them subordinate to, but have them be part of that entity and within that entity so that, as we talk about a variety of legal issues that range from their own liability all the way through sort of the structure of the state and privacy, et cetera, that they're encompassed within the program and in that way. But we can certainly articulate things in a way that better expresses that value because that's what we're here to do, is talk about what needs to be adjusted and changed. Also, I think from the standpoint of people, the concept is that a person comes to the program and they are immediately working with a resource within the navigator. And the navigator is driving the part of that experience, helping them to connect, helping them to identify and work through the coverage issues. And the navigator has the ability to, and is trained and has economic resources to work as they need with consultants and others who can help them to help the consumer in that way. So I will be more interested in hearing what it is that you think that this program isn't intending to make available to resources, to navigators, and why it's not helping the silos, because at least the goal of the design was to break through those silos and to have a one-stop shop to help guide people through all of those various experiences and make sure that they weren't just dropped off at HEAU or dropped off at MIA, but they had someone to help them navigate that appeals process. I am going to just take a minute. We only have 3 minutes left, but I see that Ms. Mitchell has also raised her hand, and we want to give her the opportunity to speak as well.
Hi, thank you for that. I know it was kind of last minute. What you were just describing is not what I heard in the description or read in what you presented. It does not feel like there is a smooth paved on-ramp into this into accessing all of this help that is outlined as there was with the CHAP bill. When you are sitting with your child or grandchild who is suicidal, who is experiencing withdrawal from substance use disorder, substance use, handing off, calling this person, calling that person, this place if you have this insurance, that place if you have another, and God help you if you have multiple insurance coverages. I'm not seeing that in this plan. I need a one-stop, one call. Parents, once you've experienced it a few times, you learn a little bit more, but when you're experiencing it that first time, you don't know what to do. We're trying to divert people from getting to the point of having to go to the emergency room and sit in a fishbowl for 5 or 6 days or 2 weeks. This, I don't see that with this. I just don't. And that
Well,
scares me because
so let me allay your fears if I didn't do a good enough job of communicating the vision. But the vision is exactly that, a person who's able to come into the system and immediately be connected with a navigator, with one of the spokes who will help them, a human being who is helping them walk through all of these decisions and never drops them off and never abandons them, and is also supported by a peer support counselor, which is a term that I'm using because it's similar to what you use in CINA cases. So, but we can call however and articulate it and describe it and label it however we would like. But the idea is that you have a place that is helping you navigate. That is the role of the navigator, and navigate from beginning to end. And you have a person resource who is also a counselor, who is helping you on a different level, and that's there to support you and to help you, in addition to the navigating program that may be more technical in nature. So I welcome you to comment on how you want to articulate what that journey should look like and feel like. But Laura, the goal here is very much as you've described it. It's not to leave someone in a fishbowl. I've had that personal experience. I don't ever want to see anybody have that, experience. So I think that the goal here is very much to come alongside people and help them each step of the way, and never just drop them off and give them a bunch of phone numbers.
thank you.
So we're at 12:01. So I want to thank everybody who participated. We are going to forward this around to everybody so that people can, provide their more detailed comments. And we'll also post it on the website. Our next meeting, I think, is scheduled for December 8th. And so hopefully by that time, we will have pulled those comments together, and we'll be able to fold them into a next iteration, and hopefully some legislative language. So with that, I'm going to wish everybody a safe and happy Thanksgiving. Ellen, your hand just popped up.
I'm sorry. I'm just trying to figure out what the deadline is for submitting comments. Obviously, we have a holiday weekend right now. And so I'm trying to figure out when you're hoping to get comments.
Let's ask people to have their comments by December 2nd. So our next meeting is, you know what, Ellen, I actually don't care. I think our meeting is scheduled for the 8th. So, if you're going to give me 27 pages, which I'm fine to have, I need a couple of days to integrate them, right? We need to review them and
Right.
send
Right.
them
No,
around. So
I understand. Yeah, we were just, and I mean, I understand you did a lot of work on this. We were hoping to see this before this meeting so that we would have some time to be able to thoughtfully consider it ahead of the meeting as well.
We are where we are now. So how much time would you like?
Well, it can't be the December the 2nd. I think, if you'll accept comments before the 8th, then we'll get you comments before the 8th.
Why don't you submit your comments by the 5th so we have the opportunity to integrate them? I'm fully confident in your ability over the next 2 weeks to pull your comments together.
Thank you.
Okay, well, with that, I wish everybody a happy holiday, and I will see everyone on the 8th.